I say big thanks to us for coming around again today to join my colleagues in the Nigerian Institute of Medical Research in sharing what they've been doing, what they are still doing, and what they hopefully will continue to do with regards to contributing significantly to the delivery of healthcare to Nigerians. I have with me today, I want to start with Dr. Agatha David to my right. She's a director of research here in NIMR and a consultant pediatrician. She studied medicine at the University of Nigeria, Enugu, graduating in 1990, and obtained the fellowship in pediatrics, the ultimate in terms of academic and the professional qualifications, to be appointable as a consultant. That was in 2004. And along the line, she also obtained a master's in public health from the University of Lagos. During our last NIMR research conference, she was a guest speaker. I hope I'm right now.
The distinguished lecturer.
The distinguished lecturer.
Thank you, sir.
Guest lecturer. The overall GO of everything on that day. She's currently the coordinator of the Child and Adolescent HIV program in the Institute. And she has about 20 years of clinical and research experience. Talking about HIV, the age group that she covers, she has some peculiarities. She'll be talking to us about these things. The truth of the matter is that that particular age group constitutes about 40% of the total HIV load that we have to deal with. And sadly, that's the group that has the lowest level of compliance, detection. And you can imagine what that means with respect to the propagation of that condition within the environment. Of course, to date, since about 2002, we've had over 25,000 people enrolled in the program. And apart from the enrollment in the program within NIMR, we also have a spillover into an orphanage in Ketu. She will telling us about all those things. It's just to let us know that, yes, we are dealing with a population of people that come into NIMR, that will attract into NIMR. But at the same time, there is some level of penetration into the community to gain further insight into the magnitude or peculiarities of the problem. the in dealing with this condition, NIMR is also actively in collaboration with other agencies. And she will tell us more about those agencies. She's leading the collaboration with that team. Today, I'm happy to welcome Dr. Agatha David to this forum and also present her to Nigerians in general to share with us the problem of HIV AIDS in this particular age group. With her, and to my left is a co-researcher in person of Dr. Sabdat Kama. She's a pharmacist. She will tell us later more about what she's into. But I can share with us the fact that she got a degree in pharmacy from Ahmadu Bello University, Zaria, in 2001, and a master's degree in 2012 from the University of Lagos. She capped it with a doctorate degree in 2022 in pharmaceutics and something technology. Yeah. In 2022. Of course, she was awarded the fellowship of the West African Postgraduate College of Pharmacists in 2010. She's also been doing some work in the area of HIV. I won't let the cat out of the bag, I said. I'm sure when she starts to share the details with us, we'll again appreciate her contribution. And after that, we'll proceed to ask questions. On that note, I want to welcome us to this. Thank you for coming. And I hope you will enjoy the session.
As the DG for that wonderful introduction and the opening remarks. Dr. Sabdat, it's a pleasure to be presenting with you. Ladies and gentlemen of the press, it's always a joy to share what we do with the public. Thank you for coming, and the NIMR media team, thank you so much. The DG has done the introduction, so I'll just go into what I do. I provide clinical care to children, adolescents, and young adults living with HIV and affected by HIV as well. So the age group, as you said, that I'm concerned with are those that are age 0 to 24 years. We also look after children of mothers who are HIV positive. Children born to mothers with HIV, we look after them until we certify that they're HIV free at 18 months. Or anytime we find that they're HIV positive, we enroll them into the program. And we provide comprehensive care here in NIMR in terms of testing and treatment, checking for even resistance. And so we do comprehensive care here in NIMR. As the DG has said, we also started an outreach to an orphanage in Ketu when we found out that they had a sizable number of children living with HIV and it was a struggle for them to come here for follow-up. So we set up an outreach clinic in that facility, which is still running. We were the first institution in Nigeria to set up an adolescent-friendly clinic for children living with HIV. And that was set up in 2009 and is still running. So for in terms of research, my research focus now is on the health and well-being of adolescents and young adults living with HIV. As EDG has said, adolescents and young adults living with HIV have the worst indices in terms of treatment outcome for people living with HIV. Number one, their testing rates are very low. Their adherence to treatment is very low. And so their viral suppression is low. What this means, there is something the United Nations Coalition on AIDS, that's UNAIDS, they have set up a goal to be met by this 2025, which is called the 95-95-95 goal. This goal states that 95% of people living with HIV should be aware that they're living with it. 95% of those who are aware that they're living with HIV should be on life-saving treatment. We call that antiretroviral therapy. And 95% of those on antiretroviral therapy should be virally suppressed. In other words, when we test their blood, we do not see the virus. It doesn't mean it's not there, but it means it's so low that we cannot detect it. That is an ideal situation because when the virus is so low, we cannot detect it. They cannot transmit it. So that will help to break the chain of transmission. And the one of the SDGs, SDG 3, target 3.3, is to end HIV as an epidemic, the HIV epidemic by 2030. And if we do not meet these 95-95-95 goals, then it's going to be impossible to meet that SDG of ending AIDS by 2030. But adolescents and young adults are one of the major problems for achieving this goal. In Nigeria, studies have shown that adolescents and young adults, the testing rate is less than 25%. Many studies from across the country have shown that when you ask young people, have you ever tested for HIV? Approximately 23% will say they have ever tested, but far less than that will say that they tested in the last 1 year. So if they are not testing, we do not know how many of them are positive. And I'm going to tell you about one study we did and the astonishing figures we found of new HIV cases amongst these adolescents and young adults. So we have a lot of work on our hands to reach this population. And then when we do reach them, and they are enrolled into care, for various reasons, they do not take their drugs. And if they do not take their drugs, they cannot be virally suppressed. If they are not virally suppressed, and you will agree with me that young people, because of their nature, they're exploratory in nature, including sexual exploration, that's when they begin to form sexual alliances. So if they are not suppressed, the chances of continuing the chain of transmission is far higher. And that's why this is an age group of concern globally, not just in Nigeria. And we did a study here in NIMR early on when we found out that our adolescents seem to be failing second-line drugs. Antiretroviral drugs are in 3 categories. There are those drugs we call first-line drugs. When the person just comes, these are the simplest, these are the most favorable to the body, and in terms of cost, they're the cheapest. And they are first-line drugs, and we encourage people to remain on first-line drugs. If people fail first-line drugs, because of financial constraints in the country, we can't go and do resistant testing for them, so we just change them to second-line drugs if it is agreed that they are failing. And then it is when they are failing second-line drugs that we now have to ensure that they're actually failing, so we do resistant testing, which is done here at NIMR. So we found that resistant testing is not covered by the national program, so they have to pay for it. And that is another challenge. But here we found out that a lot of our adolescents appeared to be failing. So we had to help them to do the resistant testing. And to our surprise, they were all female at that time. All of them were totally sensitive to all the drugs. That was the time they admitted that they had not been taking the drugs. And we do adherence counseling. Every time they come here, there are several levels of adherence counseling. So when they meet the nurse, as they're taking their vital signs, we do adherence counseling. When they're meeting the doctor, we do adherence counseling. When they go to the pharmacy, we do adherence. Adherence is encouraging them to take their drugs. What are the benefits of taking your drugs? Are you having any challenges with that? How can we help? And then when all these levels fail, we have a counseling unit that counsels them specially to take their drugs. And we found that they were not taking their drugs. So we came up with this strategy of directly observed therapy for antiretroviral. We called the mothers and we discussed it, and we decided that adolescents cannot be trusted to take their drugs. Somebody must watch them swallow the medicine. and ensure that it's not locking somewhere in their mouth. So that worked for a while. Because of that directly observed therapy, a lot of them achieved viral suppression. But the problem with directly observed therapy, the parents are busy. They feel they're now old enough to take care of themselves. Some of them are going off to university where the parents are not there. So these are the challenges we're having. And so we noticed that especially as they go to university, they're still having these challenges. We decided, what else can we do to help to improve this drug adherence? We did a study sending them SMS reminders. So bulk reminders, the time they take their drugs, they will get maybe 10 minutes before they're supposed to take the drug. They will get an alert saying, and the alert was the word, they chose what they should be reminded with. Because HIV is a stigmatizing condition, and they don't want their friend to see their phone and say, have you taken your drugs? So you could say, have you watched TV today? Have you taken your orange juice? Whatever they choose, what they should be reminded with. And then this will go to remind them. It improved adherence a bit, but it was not so effective, we found. So another way of sending an SMS and then replying, that's bi-directional. So you send an SMS and they say, yes, I have, or something like that. We found that that was more effective, the bi-directional SMS. These are the level of research. They have not been adopted by the national program, and they have cost implications. But we have done the research and it's out there to show that this bi-directional SMS is effective. And then we went further to pair it with what we call peer navigation. In other words, adolescents and young adults living with HIV, but who are suppressed, who are doing well, we serve as peer navigators to those who are not doing well. So what we did was assign 5 adolescents and young adults to 1 peer navigator. So with the bidirectional SMS, this peer navigator will call them up. How are you doing? Are you okay? Are you having challenges? Can we discuss it? And also help them. If you're supposed to come to the clinic, you don't have money, can I come and accompany you? Can I help you to get your drugs and bring it to you? We found that this combination of the SMS reminders and peer navigation was able to improve adherence. It was able to improve viral suppression. But it was, like I said, it was research that has been done and published. It's there in the public domain. We're hoping that it can be adopted into routine care for adolescents and young adults. So that's what we have done for adherence. We're still looking for ways, because adherence is still a challenge. We're still looking further studies to improve adherence in this age group. Another thing is the testing that I talked about. We found that they were not being tested. So NIMR as an organization has done what we call eye tests, where young people came together and developed strategies on how to get young people to test. And they were using oral testing kits, so you can do it at home. It was all over the nation, but we found out that we're not getting a lot of positives. So we did another in certain communities. And for NIMR here, we tested 883 persons who did not know their status. They had never tested. Adolescents and young adults aged 15 to 24 years. And to our surprise, we found that 106 of them, that's 12%, were HIV positive. Now, the national HIV prevalence in Nigeria was 1.4 in 2018, and by 2023 it's said to be 1.3%. So about 2 million people are living with HIV. But you can imagine that in this study we did over a 1-year period, testing about 1,000 people, 106 of them were positive. So there are so many who are still out there, who are positive, that we're not getting to. We have to find ways to improve testing amongst these communities. What we did during that study, for those who were not positive, they were counseled, you need to test again in 6 months because of what we call window period, which I will not go into, but test again in 6 months. And then, because they're of a high risk, they're taking risks and they could get infected, they were introduced to PrEP, what we call pre-exposure prophylaxis for HIV. And this pre-exposure prophylaxis is a tablet they can swallow once a day, and the efficacy for preventing HIV infection is 98 to 99%. what we found is that young people are not ready to take these medicines because the uptake for that was only 6%. And even those who take the first dose, they collect the first month, they don't come back to collect. So we need to do a lot more. I believe I'm going to be talking about sexual and reproductive health next. I believe that we need to counsel, we need to intensify counseling for young people to understand the dangers they face with HIV. So that's about testing and adherence and viral suppression. We also found that sexual and reproductive health is a driver of poor drug adherence, poor retention in care. I'll give an example. If a young lady gets pregnant in Nigeria, all Nigerians, the mother or they may kick her out of the house for a premarital pregnancy. When she's kicked out of the house and she's struggling for survival, coming to the clinic is the last thing on her mind. Even if they don't kick her out, we know how the barrage of condemnation is. So the person is mentally depressed. They will not even take the drugs, even if it's available. So we decided that it is something we need to tackle. And here we found a spate of pregnancies amongst our young ladies, and we called them together. What is causing this? We found out that they said there is no love in the house. The major theme in their house is take your drugs, take your drugs. Do you want to die? Do you want to kill yourself? And young men that appear to show them love, they just fall for it because they believe that at home is all drug, but this person is telling me I love you. And so they're willing to sleep with them at their own detriment because, as we know, many of these young men disappeared after the young ladies got pregnant. So we need a lot of care for them. We decided to do a formal study about sexual and reproductive health of young people. We found out that they have very little knowledge about sexual and reproductive health. And this is not surprising because sexual and reproductive health for adolescents and young adults in Nigeria is focused on HIV prevention. In fact, that's how it started. It's focused on teaching them ways to prevent sexually transmitted infections, especially HIV. And so those that are already HIV infected are left, they're neglected. And we have found that it's a major driver to poor health outcomes. So we found that they have very poor knowledge. Very importantly, they don't have sexual and reproductive health discussions with their parents. We found out that there's something in Nigeria we call family life and HIV education, which is our own terminology for comprehensive sexuality education. What came out of that study is that those who have had comprehensive sexuality education in secondary school had far better knowledge of sexual and reproductive health. So it's something that we must advocate for, even for those who are out of school. We must have community ways to bring this comprehensive sexuality education to these adolescents. And then they're not having discussions of sexual and reproductive health with their parents. That, I believe, is because of our cultural norms and beliefs that sex should not be mentioned, sex should not be talked about, but this is dangerous. And so we must have a way to educate parents. Somebody said that parenting is something that you don't go to school for, but maybe through churches, through community-based organizations to educate parents on the need to discuss these things with their parents, with their children. When children ask questions, answer it. If you do not know the answer, say I don't know, and find out the answer so that you can give the right information. If we do not give them the right information, they will seek for it elsewhere. We ask them, many of them, where do you get SRH information? A lot of them is from the internet, from social media, and we know that the internet is a bucket filled with all kinds of things. So parental education through the churches, through the mosques, through community-based organization is very important so that these people can discuss these things with their families. We also found a lot of high-risk sexual behavior amongst them. What is high-risk sexual behavior? Early sexual debut. We found that 20% of the people we looked at, 400 of them, had had sex before the age of 15. That is early sexual debut. At this time, they are not cognitively ready. That's their mental processing is not ready to know how to protect themselves. So it exposes them to poor sexual and reproductive health outcomes. There is inconsistent condom use. There's transactional sex among these people who are living at home. and their parents are not aware that they're having transactional sex. There's something we call one night stand. You meet somebody for the first time, you just go have sex with the person and you go your separate ways. These are dangerous practices that lead, to acquisition of sexually transmitted infections. They lead to unplanned pregnancies. We found unplanned pregnancies among like 15% of them, and most of these pregnancies end in abortion, which is illegal in Nigeria. Therefore, they seek this abortion in places that are not particularly sanitary. And so they have poor outcomes. This means we're doing the research, but we must translate the findings of research to practice. Some of this, what we have advocated is that there should be comprehensive sexuality education to every adolescent and young adult, both in school and out of school. We should have a way to educate parents. We should have a way to provide sexual and reproductive health services that are adolescent friendly, that is timed at the time that is convenient for adolescents, maybe evenings or weekends, so that we do not disrupt their other activities, and that is accessible and affordable. We must have manpower who are trained to provide these services. We looked at 4 so-called adolescent-friendly centers in Lagos here, and we found that they were not trained. The doctors working there just had clinical education on HIV, but they are not trained on how to deal with adolescents and young adults. And if you talk to them anyhow, they will just walk out. So there is a way to talk to them, and there are training modules that can be applied so that people understand. Even those that are supposed to be counselors have not gone for training on counseling adolescents and young adults. Many of these centers, the only contraceptive they provide is condoms, and that is not every time. And these children will probably not want to go outside to go and buy a condom because it will be looked at very funny. So we must have a comprehensive center where they can discuss their issues and get the services they need, be it counseling, be it treatment, testing and treatment for sexually transmitted infections, contraceptive care, and even when they get pregnant, there must be a place where they can be sure that they will go and get appropriate care. Studies have shown that pregnant adolescents have the worst outcome of pregnancy. They have the worst maternal mortality associated with pregnancy. They have the poor baby outcomes with low birth weight, prematurity, babies not thriving, and infant deaths. Therefore, it is something that is so important that we need to look at it as an issue. The last, but certainly not the least, is mental health. Mental health is another challenge. Adolescents and young adults living with HIV have a lot of mental health issues. As a matter of fact, globally, 50% of mental health problems have their origin in adolescence. They begin in adolescence, but many times they are not recognized. And then they go on to manifest later in life. We've done 3 studies here, and all 3 studies have shown us prevalences of depression and anxiety above 20%, prevalence of suicidal ideation above 20%. So we are currently putting together a study that will incorporate mental health counseling as part of routine care for children and for adolescents and young adults living with HIV. So what we will do is that we'll have 2 cohorts, a set that will get the routine care and another set that every month they will have mental health counseling from a certified mental health clinician. And then after 6 months, we will review the prevalence of these mental health issues amongst them. Studies elsewhere have shown that this was effective, and we're believing that Nigeria will not be different. So that is that is as per the next level of what we are going to do.
Gentlemen of the press, thank you for having me. I am Dr. Saudat Ekama, a researcher from the Clinical Sciences Department of the Nigerian Institute of Medical Research, and I specialize in drug design and formulation. I'm also involved in vaccine clinical trials, new drug molecules, and traditional and alternative medicines. My research focus is actually on designing a HIV microbicide vaginal formulation for HIV prevention in women. Globally, women are disproportionately affected by HIV. This is because heterosexual intercourse is a major mode of male to female HIV transmission, and women are vulnerable. Several HIV prevention methods have been put in place over the years, such as post-exposure prophylaxis, prevention of mother-to-child transmission, pre-exposure prophylaxis, and a host of others. But annually, HIV global statistics still reports new HIV infections. In 2024, global HIV statistics reported 1.3 million new infections globally. So this shows that there's an urgent need to design strategies to prevent new HIV infections if we have to meet the deadline and the target of SDG 3, which talks about eliminating the HIV pandemic by 2030. The HIV research project that we are working on focuses on developing a HIV prevention microbicide gel to prevent HIV amongst women. Now, a microbicide is a medicament that contains an anti-HIV agent, and it can be applied vaginally or rectally to prevent HIV infection. Over the years, researchers have actually worked on microbicide development. However, majority of them failed in clinical trials because they were fraught with challenges. Now, what our team have done was to look at the gaps and the lacunas of the previous HIV microbicide gels and look at how we can close these gaps to come up with a novel microbicide vaginal gel that will be suitable for use amongst women. I'm also interested in employing targeted drug delivery to combat the challenges of conventional microbicide gel. So we used 2 antiretroviral agents, and we looked at the challenges of leakage. Previous microbicide gels that were tested in previous clinical trials reported challenges of vaginal gel leakage upon administration, reported challenges of coital dependent use, reported challenges of wetness, and all these challenges affected adherence to its use and compliance to its use. So we have come up with a smart gel that is designed to be temperature sensitive, such that when it is liquid at room temperature, but when it is applied into the body system, it becomes highly viscous to prevent leakage. Also, we have tried to employ targeted drug delivery. Targeted drug delivery is a strategy such that you direct the drug to the site of action such that it can be delivered in a controlled manner. So we have looked at biological enzymes in the human body that could trigger the release of the drugs at the point of entry of the HIV virus. So this is what we have tried to do, to come up with a novel microbicide gel that would serve the purpose and design it in such a way to combat the challenges of previous vaginal gels. Now, this research project has gone through the in vitro preliminary research stage, in which we assessed its safety on vaginal microbiota, assessed its safety on vaginal cells, and also its efficacy on the HIV-1 BAL viral strain. Now, the results were promising, and this gave us justification to proceed to the animal model preclinical studies. For the animal model preclinical studies, we are also trying to assess the toxicity, the tolerability, and the safety in animal models. Now, in coming up with a new product, it is also very important to evaluate the willingness and the acceptability, the perceived acceptability of this product among the likely end users. So we have looked at key population. So we conducted a survey amongst key population, that is individuals who engage in high-risk sexual behavior, to assess their willingness and perceived acceptability for a future microbicide product. We were also able to assess the challenges they are facing with the currently available HIV prevention methods. We assessed their perceived affordability for a future HIV prevention microbicide, and also we assessed what they would want to see in a future microbicide agent. So all this information we gathered together, and this is going to help us in product design so that we could allow the likely end users to co-create with us, and this will foster future acceptability of the product. The research is currently in the preclinical stage amongst animal models, like I said, and we look forward to favorable outcomes, which would be a precursor to human clinical trials. Thank you for your attention.
My questions won't hesitate to the problem. Professor here, thank you so much for that highlight, so illuminating. So my question is kind of mind-boggling. I'm beginning to see the trends of contraceptives among adolescents as a secondary school girls. That is really alarming and dangerous. So I saw these trends on social media recently. By secondary school, I think in Lagos or part of Nigeria, while they were scolding a secondary school girl, like from SS1 to SS3, right? And while scolding her, teacher discovered that she was bleeding from this part of the hand. And she was scared and said, what happened to you? So they asked her to pull her clothes, and when she pulled her clothes, they discovered that there's a chip.
Implant, yes.
Yes, there's a chip here. And they were taught that what's the treatment for, and was discovered there's a kind of contraceptive. So when you're talking about contraceptives, so I don't really know, I want to share more light. I know condom is the latex condom is the commonest thing for. And there was a time NIMR, the university does things that encourages, condom among, really, yes. But that's part of the contraceptive. So, and then when you talk about the mental health, I know that here in clinic,
Yes.
they said we drug called risperidone. Risperidone is
Yes, the risperidone,
yes. So when it is a neuropsychiatric medication,
Yes.
so I don't have a psychiatrist that administers such drugs. So I want to know that. So my second question goes to Dr. Santa, who knows for that. And then my question is that gel you were talking about, I know gel, that gel you say is it cancerous? Thank you.
Please just take note of the questions.
Okay, sir.
Yeah, please go ahead.
Okay, thank you for that insightful presentation. Of course, it's in you. So we have this high body of pediatric HIV, and Nigeria is still leading. And then the problem is still mother-to-child transmission. So I don't know what to do with that, because there is a problem. It's where we are told we are having more new infections. Yeah, that's my first question. So currently, what is being done? Because I have fear that the 2020 target, 2030 target will not be achieved. Then this is 2025. You know the 95 target. That one, already we are entering Vermont. What the statistics? So that is for mother-child transmission, because that's the data from the NAC, which is still very, very high. Then coming to adherence, yes, you mentioned very fantastic approach when the SMS and brought another one. And there are two which is very effective, but have not been adopted by the national, into the national program. So what is the project? Because I know I've interacted with young people through Apple Clinic, Professor, Suleiman gave me access to them. So many of them told me that they don't take their drugs, even when their parents force them, they will hide it somewhere and pretend to take it. Some are scolded. But I noticed that this adherence, of course, we have had that interaction before engagement. At what age should parents communicate the message of, let a child know the HIV symptoms? Because some of them, they told me that they are taken to clinics every time, take this medication. Then their siblings are not taking. They started querying why they should take that medication because they were not aware at the beginning. So, in terms of their status, I mean, children are pediatric. At what age should mothers, should parents, not mothers now, communicate to them? Now, why has this strategy of adherence for these adolescents and young people, and why has it not been adopted? And if not, if this particular strategy has not been adopted currently, what strategy is the government using? Because we still have this problem of 40% of them contributing to the burden of HIV. So we can't be probating and abating why the solutions are there, they are not being adopted. So what are the problems? Is it that they are not aware, or we have a strategy on ground working but not effective? These are my questions.
Thank you.
Go.
So, we talked about this drug that people with high risk of HIV should take.
Oh, okay, the prevention.
Yes. The last time I did a report on that, I noticed that it's not available to everybody. I want to know about it.
Okay.
Yeah, I actually wanted to go there because we've done, like I've done stories on prophylaxis, we've done some programs on it, and it's where it was is where it still is. So what's the way forward? What should be done? Because people need it, and we all know that men sleeping with men, and because they do, that's what they are advised to. But I know that in most of our clinics and hospitals, those things, those classes, it's not that big. So what's the way forward? Just a follow-up to what she asked.
Thank you.
The final question is on funding, ma'am.
On
Funding.
funding, yes.
Some of these research work we carried out on the HIV and regarding children. Where are you getting the funding from? Is it from the government, or you get grants to do some of this funding? And a follow-up question, the drugs you administer. We have this here again when you export their food, that the drugs will no longer be available. That was their objection. But we want to know
The updates.
Yes.
Thank you.
So, as far as I can remember, comprehensive sexual education has been funded. Don't you think beyond that? Because I still have issues, because from all you said, there's an increase. So what do you think there should be engineering in terms of sensitizing people in some other way? Should just be comprehensive, a breakdown in some of these things, so that people can quickly understand that this danger is something that is threatening our population.
Okay.
Okay, my question is on the 95s that you mentioned. I want to know exactly what we have right now for the 395s. And secondly, the drugs for viral suppression, and adherence. I know that WHO approved 2 injectables that people can take, I think, twice a year in order to aid adherence. So why are we not using those here instead of people taking drugs every day? They are not really interested.
Thank you.
Yeah, go.
Pharmacist.
My question is my question goes to the adherence for these young adults. Now, the toxicity of these drugs, don't you think that it might probably contribute to them not adhering to this taking the drugs, and then they interact amongst themselves, probably word of mouth and everything. Is there a research to know how they interact with each other and maybe telling don't take this, don't take this?
Thank you.
I think you were going to.
Oh, okay. It's just about the traditional medicine. Like, what can be done to recognize our own locally produced traditional medicine? Because sometimes we have some drugs that have been accepted in society, not accepted because, just like what she said, they're not passing through the right channel. But I know that by now we should have some drugs that could have gotten a step away from where it was. So has there been any, and there are none, what part is NIMR playing? That
A cohort drug? Oh, sorry.
My question is so I want to ask if the target audience for the study, the health and well-being of adolescents and young adults living with HIV. I don't know the particular approach in terms of awareness creation to target this particular audience, members of the public, which are the adolescents and young adults. Have there ever been any social media campaign in that regard?
Thank you.
Last
Sorry,
question.
so that I don't take you back.
I hope
Based
you're
on
right.
the question he asked in terms of contraceptive for
Young
young
persons.
people. First, that story, fact check, wasn't true. It was everywhere. So, but coming to that, because I was even in a training maternal and child and adolescent health program when the news came out, they forwarded it to the group. So they started quoting, adolescent, why should they go that far? It's just condom, condom, condom. Now I want to ask for them, in terms of contraceptives, should it be limited to only condom? Because even some of the experts there, they are saying it's just condom that they should just have access to and be limited to. So I just want to get that if they can also have other methods of contraceptive, that is for the young adolescent.
Yes, is there any collaboration with the Ministry of Education towards taking this campaign to schools, where research like sexuality education, and what are really progress?
Thank you.
Okay. John.
Good morning, everyone.
Good morning.
Sorry, I came in late. I just glanced through your presentation. I saw that you talked about issue of mental health and HIV. And in a month's time, Vanguard will be having their annual summit on mental health. And we're looking at incorporating HIV in mental health. You said we have high prevalence of mental disorders among, can you tell us, how frequent you see them from your experience in the hospital? How frequent do you see these numbers? Are there figures to it?
Yes.
Okay. So I guess that would go. Let me just check in. Ma, is it possible for us to maybe have an idea of the number of adolescents living with HIV? Has anything been done, on that? And then when we talk about research to drugs and all that, are you working, based your research now, are you working with any maybe pharmaceutical company? And I know that it will take a lot of time, research and all that before you get to marketing stage and all that. How long do you think we will likely wait to have such drug for use in the country?
Thank you very much for all the questions. Very insightful. I will start with the contraceptives. The effectiveness of contraceptives varies. While the condom can prevent up to 95% of pregnancies, and condoms are also effective for the prevention of sexually transmitted infections, adherence to condom is an issue, and condoms must be used appropriately. You are aware that if it's not used appropriately, it can roll out. during the sexual act. And so young people sometimes, especially young adolescents, struggle to use condoms. And in fact, during this study, we asked, does condom reduce sexual pleasure? And you'll be surprised that a lot of them say yes, it reduces sexual pleasure. So that also affects adherence. But what is advocated by the World Health Organization, especially for young adolescent girls, for adolescent girls and young women, is what we call long-acting reversible contraception, such as the implant. The implant, they don't have to think about it. It can stay there for months to years. And it releases the chemicals, gradually. It's effective, it's more than 98% effective. They don't have to think about adherence, and it is reversible. So when they want to get pregnant, it can be removed, and within 6 months or thereabouts, they will get pregnant. The long-acting reversible contraceptives are the implants, the injectables, and the IUCDs. IUCDs are also, that is intrauterine contraceptive devices like the copper T and all that. I personally will not advocate for IUCDs for very young adolescents because it predisposes to bleeding sometimes. So, but the implant and the injectable is good for adults, and that is actually what is advocated because sometimes the sex for young people is not planned. It happens when they meet. So they may not remember. There is no condom at that time. There was a time here, I said it at somewhere in the auditorium, adolescents should begin to carry condoms in their bags, the females. So that when the guy says, I don't have, you bring it out. But we know that this is difficult. But if they have an implant, when you have heard that the story is false, because ideally there should be no bleeding from there, you don't even notice it. It's just a small nick and they put it there and then you don't notice it. They don't have to think about it. And they're protected because unplanned pregnancies are dangerous for the well-being of children. It truncates education and future economic stability for them. A lot of our children that became pregnant here stopped going to school. And when they don't go to school, their achievement in life is limited. Then they may decide to go and abort it. They could lose their wombs, they could bleed, they could lose their lives. And if they don't do any of that, they could become infertile because of the subclinical infection that occurs because of unsanitary abortions, and they may never give birth. And then even if they decide to carry the pregnancy, there are challenges with that. They have a more difficult pregnancy. They are more likely to develop what we call eclampsia, high blood pressure, and fitting in pregnancy. They are more likely to lose the baby, and they are more likely to lose their lives. So we must do everything that is possible to prevent early and unplanned pregnancies in children. And long-acting reversible contraception, including implants, is what is advocated for young people. Our people seem to have a lot of fear. How can a young person, and there is this myth going about, that once they use contraception, when they want to get pregnant, they won't. It's not true. You can't remove it today and get pregnant today, quite all right. But within 6 months, when the drug would have cleared from the system, the person can get pregnant. So I hope that answers your question. Yes, mother-to-child transmission is still, Nigeria has the largest gap for mother-to-child transmission. In other words, there are so many pregnant women that are not even aware of their status. So they're not getting antiretroviral drugs to prevent. We know that in Nigeria, women go to register for antenatal late, especially in our rural areas. In some of these private facilities, they're not doing HIV testing. A lot of our people prefer to deliver with the traditional birth attendants. Lagos State has done something very commendable in the sense that they have engaged non-traditional birth attendants, and they have told them to send their clients to just come and get tested. Or even some people go to the TBAs to test these women. And if they are pregnant, commence them on medication. There is that interplay between the TBAs in Lagos and the government. It's not like that everywhere. And so I'm not surprised about the gaps we're having. Where there is effective prevention of mother-to-child, in NIMR here, we have not had a positive child for more than 6 years. Because of effective, the drugs, they work, but the women have to access the drugs. So we have to intensify our campaign, scale up to make sure that in the smallest nook and cranny of this country, pregnant women, even women before they become pregnant actually, have access to know their HIV status. And then if they are positive, be started on treatment. That is the way to ensure that our children come out negative. Adherence, adoption of effective strategies, it's funds. This SMS, it costs money. And the government is not providing the drugs. The drugs come from donor agencies. And if we are getting the drugs from donor agencies, talk less of additional things that we can do. Before, in the care of people living with HIV, we did CD4 count, we did hemoglobin, we did liver function tests and renal to know how their organs are doing. Like somebody asked about toxicity. We know that some of these drugs can be toxic, so we need to do this test to ensure that the body is tolerating the drug well. But now they've been removed because the funding for those are no longer coming in. And so people here in NIMR, because we're a research institute, we insist that our clients do this test so that we're not just pumping them with drugs that may be dangerous, but they have to do it with their money. Admittedly, thank you, sir, with a discount here, but they have to do it. So that's why some of the, not that the government is not aware that these are efficacious, but the truth is that we're a low income, well, maybe middle income, I don't know what we are, but we certainly belong to the low and middle income countries. So, so funds for some of these things are the problem. Age of disclosure of HIV status. We call it age-appropriate disclosure. And we have found out that when children, especially when they become adolescents, adolescence is the age of asking questions. And if you do not explain, they just rebel and they're not taking it. But we should have started, say, from the age of 5, to begin to tell the child why you are swallowing medicine. Because what you pointed out is a legitimate concern. Their siblings are not taking drugs and they're taking. Some parents, I'm very sorry. Some parents have been innovative and have, some parents have been innovative and they, all her children take drugs at the same time. Some are taking multivitamin, and those that need ARVs are taking ARVs, so that everybody takes medicine at the same time. However, it's better to tell the child. So we have what we call age-appropriate disclosure. So like from the age of 5, you tell the child that you and your brethren, they are the same thing, but your cells need to become stronger. So you know those soldiers in the body that fight infections. These drugs, they're helping to equip the soldiers to make them strong to fight and all that. And then as they get older, we begin to explain further. Certainly for us, we believe that by 12, every child should know that they're living with HIV. I've had parents here who told me that you cannot disclose. My child will go and die, blah, blah, blah. One of them, by the time I was telling the daughter said, I know. And the mother was shocked. The mother said, how did you find out? She said, I hear they talk about it. They think we don't have ears. When you go to the lab, they're always talking about HIV. So I went to Google my drugs. And the mother said, and you didn't tell me. She told the mother, did you tell me? So, one, go, let's drop. Anyhow, we encourage our parents because some of them are so afraid of telling their children, especially the mothers, because HIV, mother-to-child transmission, is transmitted from the mother to the child. So it's a very difficult thing for a mother to tell her child. We understand that. In South Africa, they had a strategy where the parent would disclose unless they cannot disclose. But what we found here in NIMR is that we disclose with the parents because the parents say they can't say it. So we ask them to bring the child and we disclose together. And for all that we have disclosed, there has not been a negative outcome. The children will cry and then my phone is on every time. Night, I tell them, you can call me anytime, and the other members of the pediatric team. If you have any question, any doubts, anything you don't understand, call us. We'll try to find an answer for you. We do not say, we tell them it's an illness that requires you to take drugs every day. If you take your drugs every day, you can be whatever you want to be. You can grow to old age. However, if you stop taking your drugs, it will be dangerous. You will start falling sick, you will develop rashes, you will become very thin. People will not like to associate with you because you'll be looking very funny. But if you take your drugs, you're going to be looking beautiful, you're going to be looking healthy, and a lot of them do that. I only know of one case where a mother disclosed outside of here to her son who became very violent towards her because he blamed her for it. And that case, even though he's no longer even a young adult, he has passed 24, but they're still having challenges because of it. But these are rare. This is a rare case. So we should tell our children, because if they know why they're taking drugs, they are more likely to adhere. PrEP, sorry? Oh no, we don't have psychiatrists in house. Maybe the DG can help us and employ one. But we don't have in house. We usually collaborate with the neuropsychiatric hospital. So like this study that I'm talking about, we'll have to collaborate with them. We don't have one in house. Okay, then PrEP availability to everybody. Again, is about funds. PrEP is for high-risk cases. The high-risk cases are people that are in a discordant relationship, especially marriage. So if one partner in a marriage is positive and the other is negative, they qualify for PrEP. People that are female sex workers or people that are engaged in high-risk behavior that are recognized, they qualify for PrEP. Men that have sex with men, they qualify for PrEP. Adolescents, by reason of being adolescent, qualify for PrEP. PrEP, like in NIMR, may not be available, but PrEP is available in one-stop shops for key populations in Nigeria. And anybody, I had a case of one of my children that was getting married, and the husband had to access PrEP from a key population center, and they gave it to him because he qualified for it. So because we cannot afford to get PrEP for everybody, it's only for the populations that need it the most. But the problem we have with PrEP is not availability, it is adherence. Even the people that need it are not accessing it. If they access once, they don't come back. So I think it's for the awareness to grow. A lot of them believe you can't just be taking drugs. Somebody has talked about that. These drugs, they will damage the body anyhow. So you have to be careful. Those are some of their concerns, the toxicity of the drugs. But the drugs have been tested over more than 10 years, and they've been found to be safe and effective. So it's to keep encouraging people to use these drugs. Funding for our studies from where? NIMR funds some in terms of federal government. And then we get funding from outside agencies like the National Institute of Health in the US through collaboration with bodies in the US. We've worked with Northwestern University, we've worked with St. Louis University, and people like that. And there's also people have direct grants from NIH. There are also other grants. We've had Pfizer grants, we have Novartis grants, that is pharmaceutical concerns, MSO grants. So these grants come from various places. Funding challenges for ART. ART, I think the Nigerian government, the Trump administration is a wake-up call, not just for Nigeria, but for many African countries. Because if you're depending on somebody to give you food, and the person is not obligated to give you food, they could decide that I've given you enough food, you should have been able to cultivate some food by now. So when they first announced that, they would stop it, the federal government, I think they voted some 4 billion naira or thereabouts to procure drugs for a while. And then Trump relented and said for life-saving, they will continue. And ART is considered life-saving. So that's why they are continuing it for now. The truth is we should all wake up, because we don't know what is going to happen tomorrow. I think it's interesting that as big as we are as a country, there is no company that manufactures antiretrovirals in-house. Whereas India, we're getting a lot of our drugs from India. So we may start from improving or establishing enabling environment for indigenous pharmaceuticals to start to manufacture these drugs. So that's just my opinion. But we can also have MOUs with Indian organizations to send us these drugs. Comprehensive sexuality education is taught in schools. So some of the children that went to school in this study that I just finished, they said they didn't partake of the class or they can't remember. So, but what about the out of school adolescents? They are the ones that have the worst knowledge. They are the ones that have the worst high-risk behavior. How do we get this across to them? And that's why I'm talking about community strategies, maybe through churches, maybe community-based organizations. But we must get these young people outside of formal school environment, engaged in this thing to educate them. It would be nice, you are the media, if you can develop jingles or something from time to time to inform, that would be nice. And we're willing to work with anybody that wants to develop something like that. So it comes on from time to time and young people hear. 95, 95, 95, where are we? As a matter of fact, I think I was looking at a paper and about 80-something% of Nigerians living with HIV are said to know their status. But amongst adolescents and young adults, just about 60-something%. And that is an estimation because, like I said, when we did our study and we're able to see 106 people out of less than 1,000, it means there is a lot more that we do not know about. And then for many of those that know their status, more than 90% of them are linked to care. And of those who are linked to care, at the latest, 93% or so are suppressed. That's global, but this suppression is far less amongst children, even those aged 0 to 14 years, and those that are 15 to 24. The suppression rate is less than 80%. In NIMR here, our suppression rate is about 92% amongst our adolescents and young adults. But we know that NIMR is not reflective of what happens everywhere. Just like I talked about our mother-to-child transmission rate that has been 0 for a long time. If we presented that, they'll say, oh, Nigeria is doing great. But it doesn't translate like that. But we do the best that we can. Injectables are out, but you know that Nigeria will get it because we are not in direct control of what we use. It is when they give it to us that we will have it. So it has not gotten to us yet. And we hope that it will, because I'm really looking forward to it, especially for these adolescents. It will hopefully improve adherence and viral suppression amongst them. But we haven't gotten it for now. Target audience for study social media. Somebody asked about social media. Yes, that our peer navigation was through social media. They engaged through WhatsApp, through Tinder, through Badoo, and some others that I do not know about. I'm an elderly person. But usually these peer navigators engaged did HIV education and asked people if they wanted to test. And then they connected with them. And those people said where they wanted to be tested, in their homes, in their offices, or at a neighborhood park, in a petrol station restroom. They did that. And so they went to test them. And then if they turned out positive, they took them to a center to confirm it. And if it's confirmed, they ensured they were enrolled to care. And those that were negative, they offered PrEP. And those that were willing to do it. So we make use of social media to propagate what we're doing. Collaboration with Ministry of Health. It's not at the purview of NIMR, but at the purview of the Ministry of Education, Ministry of Health. So I know that NASCAP collaborates with the Ministry of Education, for instance, for this comprehensive sexuality education, though there is collaboration in that regard. Mental health challenges in young persons. So for anxiety disorders, I believe it's about 28%. Depression is about a quarter. And then suicidal ideation, that is, have you ever thought of ending it? I was surprised that it was almost 20% amongst our studies. So, and these children, as a matter of fact, we actually started we started it as an adolescent support group before we started the clinic, was because one of our children tried to kill himself with Septrin. Then they used to take Septrin as an adjunctive drug. You know, those that were not, that the CD4 count was less than 200. So he swallowed a lot of, so when we saw him with the skin and everything, and then we started asking questions, and he said, oh, his mother had passed. His stepmother, who accepted him initially, now had a baby and insisted that he must leave the father's house, that her child cannot stay with an HIV positive child. And the father agreed with his new wife and sent away the son, who was 9 at that time. And you can imagine that this 9-year-old wanted to end it. So we felt that it was imperative that we bring them together so that they can even have peers to talk to and know that they are not alone in this. I'm glad to say that he has started work, he has finished school, he's working. And so those are the things. These mental health issues, they are very real. And that's why we're thinking about bringing mental health counseling, because we are not trained. We're not trained to offer this counseling at a large level. That's why we're bringing a mental health specialist, psychiatrist, to talk to them, and we hope that it will improve the prevalence. If it does that, we can then advocate for the inclusion of mental health counseling as part of routine HIV care. Number of adolescents living with HIV in Nigeria, that's a bit challenging, because the way we do our numbers is we have children who are 0 to 14, and then the number 15 to 49. So we have to see, we know that for children 0 to 14, we have about 140,000. But for adolescents and young adults, that should be maybe about 300,000 or thereabouts, because our prevalence rates are low. But it's a huge number, because if you don't do anything about it and they propagate, then it's a multiplier effect in HIV and the mother-to-child transmission from mother to child. If a woman genuinely says she doesn't know how she got it, if she went to a reputable lab where they observe sanitary methods of blood taking, you know that here we don't reuse needles in our interactions in the labs and the hospitals. So it will be very difficult to acquire HIV from a reputable lab. So I don't know how she acquired it, and I will not be able to say. But I know that a lot of it is through sex. And I have had women that by the time you pin them down, the truth will come out. I'm a woman too.
The question on if the gel is cancerous. Yeah. Well, like I said, if you remember from my presentation, I talked about safety studies. Now, safety studies is something you carry out all through the phases of drug development. This is because whenever any drug is new, you have to watch out and rule out for toxicities. Yes. So we have conducted the in vitro phase, and I told you that we conducted in vitro studies using HeLa cells to rule out toxicity on vaginal cells. Now, for the animal model studies, we are also conducting toxicity studies, safety studies on vaginal cells. Now, if you move on to human clinical trials, you are also going to conduct safety studies. Then even after when the product is approved for use, you are still going to monitor for side effects. So it is something that is ongoing and is something that we are looking out for. So for now, the gel is not cancerous, but we are watching out for, you understand, any side effects, toxicities that might be associated with the product. Yeah. The second question talks about what can be done with the aspect of traditional alternative medicines. Am I right? Okay, there's a department in the institute, the biochemistry and nutrition department, in which we have the Center for Alternative and Complementary Medicine, headed by Dr. Oluwabemiga Aino. He actually collaborates with individuals who have claims on alternative medicine products, in which they try to help them scientifically validate those claims by subjecting these products to preclinical studies, animal model studies. At least we've had like 2. I have the opportunity to work with him on some of these products. So we've had at least 2 products or more that have gone through what you call proof of concept studies. A proof of concept study is a study you conduct on few individuals before the main human clinical trials. So that is the much I can say about what is being done to scientifically validate the claims of alternative medicine products. I guess in a better forum, the head of that team will be able to say much about that.
During the COVID, we tested a drug that was a traditional drug that was discovered at Afebabala University, and they reached out to us to test it. So it went through preclinical studies and clinical studies, and we showed that that drug was superior to standard of care. That's just offering symptomatic treatment in treating people that contracted COVID. So that's one that went through a full, it was still proof of concept, but we tested it amongst 50 people. And they recovered faster than those that were making it, and they didn't have any complications. So, and I'm sure such studies are ongoing as well.
Yes. We are also rounding up another proof of concept study on some products for prostate cancer. But like I said, I wouldn't want to let the cat out of the bag, because the team lead for that study is Dr. Oluwabenga Aino. So if the DG permits, I guess in another forum you'll be able to discuss in depth on that. Then the last question here says, are you working with any pharmaceutical company, and how long do you think it will take to have the products for use in circulation? Well, at some point we plan to collaborate with pharmaceutical companies, but like we are a research institute, and right now we are still working on the animal model study. So at some point we would collaborate, and the how long it will take for this product to be available is subject to the outcome of animal model studies, the outcome of human clinical trials, and the outcome of the collaboration with pharmaceutical companies. So I might not be able to categorically tell you this is how long it will take, and also subject to availability of funds. So there are a lot of factors revolving around that. But we hope that we would be able to come out with the product. Thank you.
Again, I thank you for the patience and how we have digested the information given to us, evident by the various questions asked. And I want to seize this opportunity to say a big thank you to my colleagues for presenting to us what they've been doing. I'm happy Dr. Ekama applied the brakes with regards to the aspect of alternative medicine. Doctor, I know will be talking to us later on. But I can assure us that NIMR is involved actively in some collaborative studies. Some are showing prospects, some are likely to be discarded. But again, I want to wait until Dr. Ano comes to talk. We had discussion yesterday about a particular one. And I said we might have to discard it. We have listened to what NIMR has been doing in the area of HIV, particularly as it affects children, adolescents, and how some of this will have been monitored into adulthood, some of them graduating from the university, some of them married and living a happy life. So the outcome has been generally good, at least those that have been managed at a center and monitored. We've also listened to developments concerning the vaginal microbicide gel from Dr. Ekama. All in all, we're hoping that if some of these outcomes are seriously taken, it might assist in lowering the burden. I want to seize this opportunity to let Nigerians know that NIMR and the experts working with it are doing a lot to create or attempt to create a healthy environment. Yes, we had some temporary, or we had a temporary cessation of assistance. But the good news is that the wealthy nations are coming back. One of the major NGO that has come back with the assistance of the US government is EQUIS. And EQUIS is assisting NIMR once again to recommence work with regards to HIV testing, distribution of antiretroviral drugs, and keeping our laboratory going. Something came up in the course of the presentation when we're talking about adherence. And you ask people, they tell you, oh, we are taking our drugs. What's the percentage of them that are taking these drugs? One of the NGOs is actively looking into the determination of the accuracy of the information that we're getting from respondents. Is it really true that people are taking their drugs? Is it really true that the distribution within the community has been reduced? And what they did was to now take blood they started taking blood in selected states across the country. Before now, they were sending samples of this blood to South Africa for analysis. And 2 weeks ago, they approached NIMR, we had discussions, and they want to see if NIMR could be encouraged to move into this sphere and do the analysis. And once they are sure that it's the same results that they can get from South Africa, they can as well rely on NIMR. And just this morning, before I came to this meeting, a representative of the US CDC was with me. Wanting NIMR well, they've been working with NIMR for some time, but they now want NIMR to come on and become a regional HIV drug resistance testing laboratory for West Africa. And while having that conversation, I had to call in the acting HOD of Clinical Sciences Department. I called in the head of microbiology those two are available to meet with him. He's going to be with us again tomorrow. But the big boss from the US will be joining us next month for a few days. And I'm hoping that at the end of the day, they would have seen the capabilities of NIMR, probably also areas through which they can provide assistance and be able to continue the fight against HIV. On this note, I want to say a big thank you to Ross for coming once again.